Welcome, everyone. Today, we're going to do a deep dive into one of medicine's most legendary tricksters. This is an infection that has been fooling the best of us for centuries, and I guarantee it's something you will see and need to recognize in your own practice.
Of course, we are talking about syphilis. There's a very good reason it's called the great imitator. One day, it can walk into your clinic looking like pityriasis rosea. The next, it can look like psoriasis. That's why keeping a high index of suspicion isn't just, good practice. It is absolutely essential. So let's get right into it.
Here's our game plan. We'll start with a little history, then we'll walk through the many clinical phases of syphilis, get into our diagnostic strategy, line it up against the other usual suspects, and then we'll finish up by talking about the challenges we're all facing today.
All right, section 1, the history. To really understand this disease, to predict its moves, you've got to know where it came from.
The timeline of syphilis really mirrors the timeline of modern medicine itself. We're talking about a disease named in a poem back in the 1500s, all the way to finally identifying the bug Treponema pallidum in 1905, and then, of course, the game changer, penicillin in the 40s. But it's also a history that is deeply scarred by some unbelievable ethical failures that, frankly, still affect our patients' trust in the system today. And this slide just lays that contrast out so clearly. Look at the Oslo study. This was pre-antibiotics, and it gave us some pretty grim but absolutely vital data on what this disease does when left unchecked. About a third of people developed that awful tertiary stage. Then you have the Tuskegee study. This was a catastrophic ethical failure, where treatment was actively withheld from Black men. It caused incredible harm and created a legacy of mistrust that we are still fighting against in our communities.
Okay, section 2, the many faces of syphilis. Now we're getting to the core of it. This is what's going to walk through your clinic door, and you need to be ready. If you don't treat it, this disease really progresses like a 4-act play. It starts with a single, localized ulcer. Then it goes systemic and explodes with all sorts of signs. After that, it can go quiet for years before its final destructive act, which can cause severe organ damage.
The primary chancre is a masterclass in deception. It's usually a single, firm ulcer, but here's the key word, the one that trips everyone up: painless. Because it doesn't hurt, a patient might not even notice it. To make things worse, it heals all by itself, giving a totally false sense of security. And if it's internal, say on the cervix or in the rectum, forget about it. It's almost always missed, which means the first time you see that patient, they could be well into the next stage.
So weeks or months go by, and they're back in your office. This right here is where syphilis really lives up to its name. The spirochete has gone systemic. It's everywhere. They might complain about feeling run down, maybe a low fever, but it's almost always the skin findings that bring them to a dermatologist. The classic sign you have to look for? A generalized, non-itchy rash. And this is where you need to have your mental checklist ready. You have to look for the classic signs. Check the palms and soles for those papulosquamous lesions, maybe with that textbook colorative Bates. In the moist, intriginous areas, look for condylamida lata. And please don't mistake them for warts. Check inside the mouth for mucus patches. Look at the scalp for that classic moth-eaten alopecia. These are the telltale signs of a systemic disease presenting on the skin. And here's a really important pearl for your practice today. In your immunocompromised patients, especially those living with HIV, you need to be on high alert for a much nastier presentation. It's called loose maligna, and it shows up with these awful ulcerative necrotic lesions. It's a severe variant, and it demands immediate recognition and treatment. So after that secondary stage fireworks show, the spirochete can actually go into hiding for years, sometimes decades. This is the latent phase. The patient feels fine, but their blood work is still positive. And for about a third of those people, the disease comes roaring back in its tertiary form, causing destructive skin lesions called gummas, catastrophic cardiovascular problems, or the devastating neurological decline of neurosyphilis. Section 3. Unmasking the spirochete. Okay, so your clinical suspicion is buzzing. Now here's how you use the lab to prove it. Look, if you remember one thing about testing, make it this. We have 2 different types of tests. The non-treponemal tests, like the RPR, are our workhorses. We use them for screening and, this is crucial, for monitoring treatment because the titer tells you about disease activity. The treponemal tests, like FTA-ABS, are for one thing only: confirming the diagnosis. And remember, these almost always stay positive for life, even after you've cured the patient. So, the classic way to do this is simple. You start with a screening RPR. If it comes back reactive, you order a specific treponemal test to confirm it. Nice and straightforward.
But you have to know that a lot of big labs are doing it backwards now. They use a reverse sequence. They start with the specific treponemal test because it's easier to automate. If that's positive, then they run the RPR to see if the disease is active and to get that all-important baseline titer. So just be aware of which algorithm your lab is using when you see the results. Now listen up, because this is a huge diagnostic trap. If you have a patient who is just covered in a classic secondary syphilis rash, but their RPR comes back negative, you have to suspect the prozone phenomenon. It's a false negative that happens when there's such a massive amount of antibody that it messes up the test. Don't let it fool you. Call the lab and tell them to dilute the serum.
All right, Section 4, the usual suspects. So a patient comes in with a genital ulcer. Syphilis is right at the top of your list, but what else should be on your differential? Think of this table as your clinical cheat sheet. Your history and physical exam give you all the clues you need to start. The very first question to ask your patient is always, does it hurt? If the answer is yes, you're immediately thinking herpes or chancroid. If the answer is no, your differential shifts right over to syphilis, LGV, or donovanosis. Then you just look closer. How many ulcers? What does the base look like? These details are what will lead you to the right diagnosis before any tests even come back. And finally, Section 5, the modern battlefield. Let's bring this all home. Why is this topic so incredibly urgent for us? Right here, right now.
Because the numbers are, frankly, terrifying. This is an ancient history. The rate of primary and secondary syphilis has been skyrocketing, especially among men, and in particular among men who have sex with men. This isn't just a textbook disease. It is a full-blown public health crisis happening on our watch. And the challenge today is really threefold. First, the incredibly dangerous link with HIV. A syphilitic ulcer is basically an open door for HIV transmission. Second, the good news. Our go-to treatment, penicillin G, still works beautifully. But third, and you have to warn your patients about this, is the Jarisch-Herxheimer reaction. A few hours after their shot, they might get a fever, headache, and feel terrible. You have to reassure them, this is not an allergy. It's the sign of a massive die-off of spirochetes, and it means the medicine is working.
So I want to leave you with this thought. The great imitator is back in a big way. It hasn't learned any new tricks, but I worry that we, as clinicians, might have forgotten some of the old ones. Our most powerful tool against it is what it's always been, a high index of suspicion. The question for all of us isn't if you're going to see syphilis walk into your clinic. The question is, will you recognize it when you do?